Section 33 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 2, by Henry Gray. The anterior vertebral muscles. The anterior vertebral muscles are longus colli, longus capitis, rectus capitis anterior, rectus capitis lateralis. The longus colli is situated on the anterior surface of the vertebral column, between the atlas and the third thoracic vertebra. It is broad in the middle, narrow and pointed at either end, and consists of three portions: a superior oblique, an inferior oblique, and a vertical. The superior oblique portion arises from the anterior tubercles of the transverse processes of the third, fourth, and fifth cervical vertebrae, and, ascending obliquely with a medial inclination, is inserted by a narrow tendon into the tubercle on the anterior arch of the atlas. The inferior oblique portion, the smallest part of the muscle, arises from the front of the bodies of the first two or three thoracic vertebrae, and, ascending obliquely in a lateral direction, is inserted into the anterior tubercles of the transverse processes of the fifth and sixth cervical vertebrae. The vertical portion arises below from the front of the bodies of the upper three thoracic and lower three cervical vertebrae, and is inserted into the front of the bodies of the second, third, and fourth cervical vertebrae. The longus capitis, rectus capitis anticus major, broad and thick above, narrow below, arises by four tendinous slips from the anterior tubercles of the transverse processes of the third, fourth, fifth, and sixth cervical vertebrae, and descends, converging toward its fellow of the opposite side, to be inserted into the inferior surface of the basilar part of the occipital bone. The rectus capitis anterior, rectus capitis anticus minor, is a short, flat muscle situated immediately behind the upper part of the longus capitis. It arises from the anterior surface of the lateral mass of the atlas, and from the root of its transverse process, and passing obliquely upward and medialward, is inserted into the inferior surface of the basilar part of the occipital bone immediately in front of the foramen magnum. The rectus capitis lateralis, a short flat muscle, arises from the upper surface of the transverse process of the atlas, and is inserted into the under surface of the jugular process of the occipital bone. Nerves. The rectus capitis anterior and the rectus capitis lateralis are supplied from the loop between the first and second cervical nerves. The longus capitis by branches from the first, second, and third cervical. The longus colli by the branches from the second to the seventh cervical nerves. Actions. The longus capitis and rectus capitis anterior are the direct antagonists of the muscles at the back of the neck, serving to restore the head to its natural position after it has been drawn backward. These muscles also flex the head, and from their obliquity rotate it, so as to turn the face to one or the other side. The rectus lateralis, acting on one side, bends the head laterally. The longus colli flexes and slightly rotates the cervical portion of the vertebral column. The lateral vertebral muscles. The lateral vertebral muscles are scalenus anterior, scalenus medius, scalenus posterior. The scalenus anterior, scalenus anticus, lies deeply at the side of the neck, behind the sternocleidomastoideus. It arises from the anterior tubercles of the transverse processes of the third, fourth, fifth, and sixth cervical vertebrae, and descending almost vertically is inserted by a narrow flat tendon into the scalene tubercle on the inner border of the first rib, and into the ridge on the upper surface of the rib in front of the subclavian groove. The scalenus medius, the largest and longest of the three scaleni, arises from the posterior tubercles of the transverse processes of the lower 6 cervical vertebrae, and descending along the surface of the vertebral column is inserted by a broad attachment into the upper surface of the first rib, between the tubercle and the subclavian groove. The scalenus posterior, scalenus posticus, the smallest and most deeply seated of the three scaleni, arises, by 2 or 3 separate tendons, from the posterior tubercles of the transverse processes of the lower 2 or 3 cervical vertebrae, and is inserted by a thin tendon into the outer surface of the second rib, behind the attachment of the serratus anterior. It is occasionally blended with the scalenus medius. Variations. The scaleni muscles vary considerably in their attachments and in arrangement of their fibers. A slip from the scalenus anticus may pass behind the subclavian artery. The scalenus posticus may be absent or extend to the third rib. The scalenus pleuralis muscle extends from the transverse process of the 7th cervical vertebra to the fascia supporting the dome of the pleura and inner border of the first rib. Nerves. The scaleni are supplied by branches from the 2nd to the 7th cervical nerves. Actions. When the scaleni act from above, they elevate the first and second ribs, and are, therefore, inspiratory muscles. Acting from below, they bend the vertebral column to one or the other side. If the muscles of both sides act, the vertebral column is slightly flexed. End of section 33. Recording by David Lawrence in Brampton, Ontario, January 6, 2009.
Grey's Anatomy Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body Part 2 by Henry Gray. The fasciae and muscles of the trunk. The deep muscles of the back. The muscles of the trunk may be arranged in 6 groups. 1. Deep muscles of the back. 2. Suboccipital muscles. 3. Muscles of the thorax. 4. Muscles of the abdomen. 5. Muscles of the pelvis. 6. Muscles of the perineum. The deep muscles of the back. The deep or intrinsic muscles of the back consist of a complex group of muscles extending from the pelvis to the skull. They are splenius capitis, splenius cervicis, sacrospinalis, semispinalis, multifidus, rotatories, interspinalis, intertransversarii. The lumbodorsal fascia, fascia lumbodorsalis, lumbar aponeurosis, and vertebral fascia. The lumbodorsal fascia is a deep investing membrane which covers the deep muscles of the back of the trunk. Above, it passes in front of the serratus posterior superior and is continuous with a similar investing layer on the back of the neck, the nuchal fascia. In the thoracic region, the lumbodorsal fascia is a thin fibrous lamina which serves to bind down the extensor muscles of the vertebral column and to separate them from the muscles connecting the vertebral column to the upper extremity. It contains both longitudinal and transverse fibers, and is attached medially to the spinous processes of the thoracic vertebrae, laterally to the angles of the ribs. In the lumbar region, the fascia, lumbar aponeurosis, is in 2 layers, anterior and posterior. The posterior layer is attached to the spinous processes of the lumbar and sacral vertebrae and to the supraspinal ligament. The anterior layer is attached medially to the tips of the transverse processes of the lumbar vertebrae and to the intertransverse ligaments, below to the iliolumbar ligament, and above to the lumbocostal ligament. The 2 layers unite at the lateral margin of the sacrospinalis to form the tendon of origin of the transversus abdominis. The aponeurosis of origin of the serratus posterior inferior and the latissimus dorsi are intimately blended with the lumbodorsal fascia. The splenius capitis arises from the lower half of the ligamentum nuchae, from the spinous process of the seventh cervical vertebra, and from the spinous processes of the upper 3 or 4 thoracic vertebrae. The fibers of the muscle are directed upward and lateralward and are inserted under cover of the sternocleido mastoideus into the mastoid process of the temporal bone, and into the rough surface on the occipital bone just below the lateral third of the superior nuchal line. The splenius cervicis, splenius cali, arises by a narrow tendinous band from the spinous processes of the 3rd to the 6th thoracic vertebrae. It is inserted by tendinous fasciculi into the posterior tubercles of the transverse processes of the upper 2 or 3 cervical vertebrae. Variations. The origin is frequently moved up or down 1 or 2 vertebrae. Accessory slips are occasionally found. Nerves. The splenii are supplied by the lateral branches of the posterior divisions of the middle and lower cervical nerves. Actions. The splenii of the 2 sides, acting together, draw the head directly backward, assisting the trapezius and semispinalis capitis. Acting separately, they draw the head to one side and slightly rotate it, turning the face to the same side. They also assist in supporting the head in the erect position. The sacrospinalis, erector spinae, and its prolongations in the thoracic and cervical regions, lie in the groove on the side of the vertebral column. They are covered in the lumbar and thoracic regions by the lumbodorsal fascia, and in the cervical region by the nuchal fascia. This large muscular and tendinous mass varies in size and structure at different parts of the vertebral column. In the sacral region it is narrow and pointed, and at its origin chiefly tendinous in structure. In the lumbar region it is larger and forms a thick fleshy mass which, on being followed upward, is subdivided into 3 columns. These gradually diminish in size as they ascend, to be inserted into the vertebrae and ribs. The sacrospinalis arises from the anterior surface of a broad and thick tendon which is attached to the medial crest of the sacrum, to the spinous processes of the lumbar and the 11th and 12th thoracic vertebrae, and the supraspinal ligament, to the back part of the inner lip of the iliac crests, and to the lateral crest of the sacrum, where it blends with the sacrotuberous and posterior sacroiliac ligaments. Some of its fibers are continuous with the fibers of origin of the gluteus maximus. The muscular fibers form a large fleshy mass which splits in the upper lumbar region into 3 columns, viz. a lateral, the iliocostalis, an intermediate, the longissimus, and a medial, the spinalis. Each of these consists from below upward of 3 parts, as follows: lateral column, iliocostalis, A. I lumborum, B. I dorsi, C. I cervicis. Intermediate column, longissimus, A. L dorsi, B. L cervicis, C. L capitis. Medial column, spinalis, A. S dorsi, B. S cervicis, C. S capitis. The iliocostalis lumborum, iliocostalis muscle, sacrolumbalis muscle, is inserted by 6 or 7 flattened tendons into the inferior borders of the angles of the lower 6 or 7 ribs. The iliocostalis dorsi, musculus accessorius, arises by flattened tendons from the upper borders of the angles of the lower 6 ribs medial to the tendons of insertion of the iliocostalis lumborum. These become muscular and are inserted into the upper borders of the angles of the upper 6 ribs, and into the back of the transverse process of the 7th cervical vertebra. The iliocostalis cervicis, cervicalis ascendens, arises from the angles of the 3rd, 4th, 5th, and 6th ribs, and is inserted into the posterior tubercles of the transverse processes of the 4th, 5th, and 6th cervical vertebrae. The longissimus dorsi is the intermediate and largest of the continuations of the sacrospinalis. In the lumbar region, where it is as yet blended with the iliocostalis lumborum, some of its fibers are attached to the whole length of the posterior surfaces of the transverse processes and the accessory processes of the lumbar vertebrae, and to the anterior layer of the lumbodorsal fascia. In the thoracic region it is inserted by rounded tendons into the tips of the transverse processes of all the thoracic vertebrae, and by fleshy processes into the lower 9 or 10 ribs between their tubercles and angles. The longissimus cervicis, transversalis cervicis, situated medial to the longissimus dorsi, arises by long thin tendons from the summits of the transverse processes of the upper 4 or 5 thoracic vertebrae, and is inserted by similar tendons into the posterior tubercles of the transverse processes of the cervical vertebrae from the 2nd to the 6th inclusive. The longissimus capitis, tracheomastoid muscle, lies medial to the longissimus cervicis between it and the semispinalis capitis. It arises by tendons from the transverse processes of the upper 4 or 5 thoracic vertebrae and the articular processes of the lower 3 or 4 cervical vertebrae, and is inserted into the posterior margin of the mastoid process beneath the splenius capitis and sternocleido mastoideus. It is almost always crossed by a tendinous intersection near its insertion. The spinalis dorsi, the medial continuation of the sacrospinalis, is scarcely separable as a distinct muscle. It is situated at the medial side of the longissimus dorsi and is intimately blended with it. It arises by 3 or 4 tendons from the spinous processes of the first 2 lumbar and the last 2 thoracic vertebrae. These uniting form a small muscle which is inserted by separate tendons into the spinous processes of the upper thoracic vertebrae, the number varying from 4 to 8. It is intimately united with the semispinalis dorsi, situated beneath it. The spinalis cervicis, spinalis colli, is an inconstant muscle which arises from the lower part of the ligamentum nuchae, the spinous process of the 7th cervical, and sometimes from the spinous processes of the 1st and 2nd thoracic vertebrae, and is inserted into the spinous process of the axis, and occasionally into the spinous processes of the 2 vertebrae below it. The spinalis capitis, biventer cervicis, is usually inseparably connected with the semispinalis capitis. See below. The semispinalis dorsi consists of thin, narrow, fleshy fasciculi interposed between tendons of considerable length. It arises by a series of small tendons from the transverse processes of the 6th to the 10th thoracic vertebrae, and is inserted by tendons into the spinous processes of the upper 4 thoracic and lower 2 cervical vertebrae. The semispinalis cervicis, semispinalis colli, thicker than the preceding, arises by a series of tendinous and fleshy fibers from the transverse processes of the upper 5 or 6 thoracic vertebrae, and is inserted into the cervical spinous processes from the axis to the 5th inclusive. The fasciculus connected with the axis is the largest and is chiefly muscular in structure. The semispinalis capitis, complexus, is situated at the upper and back part of the neck beneath the splenius and medial to the longissimus cervicis and capitis. It arises by a series of tendons from the tips of the transverse processes of the upper 6 or 7 thoracic and the 7th cervical vertebrae, and from the articular processes of the 3 cervical above this. The tendons, uniting, form a broad muscle which passes upward and is inserted between the superior and inferior nuchal lines of the occipital bone. The medial part, usually more or less distinct from the remainder of the muscle, is frequently termed the spinalis capitis. It is also named the biventer cervicis, since it is traversed by an imperfect tendinous inscription. The multifidus spinae, consists of a number of fleshy and tendinous fasciculi which fill up the groove on either side of the spinous processes of the vertebrae from the sacrum to the axis. In the sacral region, these fasciculi arise from the back of the sacrum as low as the 4th sacral foramen, from the aponeurosis of origin of the sacrospinalis, from the medial surface of the posterior superior iliac spine, and from the posterior sacroiliac ligaments. In the lumbar region, from all the mammillary processes, in the thoracic region, from all the transverse processes, and in the cervical region, from the articular processes of the lower 4 vertebrae. Each fasciculus, passing obliquely upward and medialward, is inserted into the whole length of the spinous process of one of the vertebrae above. These fasciculi vary in length. The most superficial, the longest, pass from one vertebra to the 3rd or 4th above. Those next in order run from one vertebra to the 2nd or 3rd above, while the deepest connect 2 contiguous vertebrae. The rotatories spinae, lie beneath the multifidus and are found only in the thoracic region. They are 11 in number on either side. Each muscle is small and somewhat quadrilateral in form. It arises from the upper and back part of the transverse process, and is inserted into the lower border and lateral surface of the lamina of the vertebra above, the fibers extending as far as the root of the spinous process. The first is found between the 1st and 2nd thoracic vertebrae, the last between the 11th and 12th. Sometimes the number of these muscles is diminished by the absence of one or more from the upper or lower end. The interspinales are short muscular fasciculi placed in pairs between the spinous processes of the contiguous vertebrae, one on either side of the interspinal ligament. In the cervical region they are most distinct, and consist of 6 pairs, the first being situated between the axis and third vertebra, and the last between the 7th cervical and the 1st thoracic. They are small narrow bundles attached above and below to the apices of the spinous processes. In the thoracic region they are found between the 1st and 2nd vertebrae, and sometimes between the 2nd and 3rd, and between the 11th and 12th. In the lumbar region there are 4 pairs, in the intervals between the 5 lumbar vertebrae. There is also occasionally one between the last thoracic and 1st lumbar, and one between the 5th lumbar and the sacrum. The extensor coccygeus is a slender muscular fasciculus which is not always present. It extends over the lower part of the posterior surface of the sacrum and coccyx. It arises by tendinous fibers from the last segment of the sacrum, or first piece of the coccyx, and passes downward to be inserted into the lower part of the coccyx. It is a rudiment of the extensor muscle of the caudal vertebrae of the lower animals. The intertransversarii, intertransversales, are small muscles placed between the transverse processes of the vertebrae. In the cervical region they are best developed, consisting of rounded muscular and tendinous fasciculi, and are placed in pairs, passing between the anterior and the posterior tubercles, respectively, of the transverse processes of 2 contiguous vertebrae, and separated from one another by an anterior primary division of the cervical nerve, which lies in the groove between them. The muscles connecting the anterior tubercles are termed the intertransversarii anteriores, those between the posterior tubercles, the intertransversarii posteriores. Both sets are supplied by the anterior divisions of the spinal nerves. There are 7 pairs of these muscles, the first pair being between the atlas and axis, and the last pair between the 7th cervical and 1st thoracic vertebrae. In the thoracic region they are present between the transverse processes of the lower 3 thoracic vertebrae, and between the transverse processes of the last thoracic and the 1st lumbar. In the lumbar region they are arranged in pairs on either side of the vertebral column, one set occupying the entire interspace between the transverse processes of the lumbar vertebrae, the intertransversarii laterales, the other set, intertransversarii mediales, passing from the accessory process of one vertebra to the mammillary of the vertebra below. The intertransversarii laterales are supplied by the anterior divisions, and the intertransversarii mediales by the posterior divisions of the spinal nerves. End of section 34.
Of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Suboccipital muscles. The suboccipital group comprises rectus capitis posterior major, rectus capitis posterior minor, obliquus capitis inferior, obliquus capitis superior. The rectus capitis posterior major, rectus capitis posticus major, arises by a pointed tendon from the spinous process of the axis, and, becoming broader as it ascends, is inserted into the lateral part of the inferior nuchal line of the occipital bone and the surface of the bone immediately below the line. As the muscles of the 2 sides pass upward and lateralward, they leave between them a triangular space, in which the recti capitis posteriores minores are seen. The rectus capitis posterior minor, rectus capitis posticus minor, arises by a narrow pointed tendon from the tubercle on the posterior arch of the atlas, and, widening as it ascends, is inserted into the medial part of the inferior nuchal line of the occipital bone and the surface between it and the foramen magnum. The obliquus capitis inferior, the larger of the 2 oblique muscles, arises from the apex of the spinous process of the axis, and passes lateralward and slightly upward to be inserted into the lower and back part of the transverse process of the atlas. The obliquus capitis superior, narrow below, wide and expanded above, arises by tendinous fibers from the upper surface of the transverse process of the atlas, joining with the insertion of the preceding. It passes upward and medialward, and is inserted into the occipital bone between the superior and inferior nuchal lines, lateral to the semispinalis capitis. The suboccipital triangle. Between the obliqui and the rectus capitis posterior major is the suboccipital triangle. It is bounded above and medially by the rectus capitis posterior major, above and laterally by the obliquus capitis superior, below and laterally by the obliquus capitis inferior. It is covered by a layer of dense fibrofatty tissue situated beneath the semispinalis capitis. The floor is formed by the posterior occipito-atlantal membrane and the posterior arch of the atlas. In the deep groove on the upper surface of the posterior arch of the atlas are the vertebral artery and the first cervical or suboccipital nerve. Nerves. The deep muscles of the back and the suboccipital muscles are supplied by the posterior primary divisions of the spinal nerves. Actions. The sacrospinalis and its upward continuations and the spinales serve to maintain the vertebral column in the erect posture. They also serve to bend the trunk backward when it is required to counterbalance the influence of any weight at the front of the body, as for instance when a heavy weight is suspended from the neck, or when there is any great abdominal distension, as in pregnancy or dropsy. The peculiar gait under such circumstances depends upon the vertebral column being drawn backward by the counterbalancing action of the sacrospinales. The muscles which form the continuation of the sacrospinales onto the head and neck steady those parts and fix them in the upright position. If the iliocostalis lumborum and longissimus dorsi of one side act, they serve to draw down the chest and vertebral column to the corresponding side. The iliocostalis cervicis, taking their fixed points from the cervical vertebrae, elevate those ribs to which they are attached. Taking their fixed points from the ribs, both muscles help to extend the neck, while one muscle bends the neck to its own side. When both longissimi cervicis act from below, they bend the neck backward. When both longissimi capitis act from below, they bend the head backward, while, if only one muscle acts, the face is turned to the side on which the muscle is acting, and then the head is bent to the shoulder. The two recti draw the head backward. The rectus capitis posterior major, owing to its obliquity, rotates the skull, with the atlas, around the odontoid process, turning the face to the same side. The multifidus acts successively upon the different parts of the column, thus the sacrum furnishes a fixed point from which the fasciculi of this muscle acts upon the lumbar region, which in turn becomes the fixed point for the fasciculi moving the thoracic region, and so on throughout the entire length of the column. The multifidus also serves to rotate the column, so that the front of the trunk is turned to the side opposite to that from which the muscle acts, this muscle being assisted in its action by the obliquus externus abdominis. The obliquus capitis superior draws the head backward and to its own side. The obliquus inferior rotates the atlas, and with it the skull, around the odontoid process, turning the face to the same side. When the semispinales of the two sides act together, they help to extend the vertebral column. When the muscles of only one side act, they rotate the thoracic and cervical parts of the column, turning the body to the opposite side. The semispinales capitis draw the head directly backward if one muscle acts. It draws the head to one side and rotates it so that the face is turned to the opposite side. The interspinales, by approximating the spinous processes, help to extend the column. The intertransversarii approximate the transverse processes and help to bend the column to one side. The rotatores assist the multifidus to rotate the vertebral column, so that the front of the trunk is turned to the side opposite to that from which the muscles act. End of section number 35. Section 36 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles of the Thorax, Part 1. 6c. The muscles of the thorax. The muscles belonging to this group are the intercostales externi, intercostales interni, subcostales, Transversus thoracis, levatores costarum, serratus posterior superior, serratus posterior inferior, diaphragm. Intercostal fasciae. In each intercostal space, thin but firm layers of fascia cover the outer surface of the intercostalis externus and the inner surface of the intercostalis internus, and a third, more delicate layer is interposed between the two planes of muscular fibres. They are best marked in those situations where the muscular fibres are deficient, as between the intercostalis externi and sternum in front, and between the intercostalis interni and vertebral column behind. The intercostalis, intercostal muscles, are two thin planes of muscular and tendinous fibres occupying each of the intercostal spaces. They are named external and internal from their surface relations, the external being superficial to the internal. The intercostalis externi, external intercostals, are 11 in number on either side. They extend from the tubercles of the ribs behind to the cartilages of the ribs in front, where they end in thin membranes, the anterior intercostal membranes, which are continued forward to the sternum. Each arises from the lower border of a rib, and is inserted into the upper border of the rib below. In the two lower spaces they extend to the ends of the cartilages, and in the upper 2 or 3 spaces they do not quite reach the ends of the ribs. They are thicker than the intercostalis interni, and their fibres are directed, obliquely downward and lateralward on the back of the thorax, and downward, forward, and medialward on the front. Variations. Continuation with the obliquus externus or serratus anterior. A supracostalis muscle from the anterior end of the first rib down to the second, third, or fourth ribs occasionally occurs. The intercostalis interni, internal intercostals, are also 11 in number on either side. They commence anteriorly at the sternum, in the interspaces between the cartilages of the true ribs and the anterior extremities of the cartilages of the false ribs, and extend backward as far as the angles of the ribs, whence they are continued to the vertebral column by thin aponeuroses, the posterior intercostal membranes. Each arises from the ridge on the inner surface of a rib, as well as from the corresponding costal cartilage, and is inserted into the upper border of the rib below. Their fibres are also directed obliquely, but pass in a direction opposite to those of the intercostalis externi. The subcostalis, infracostalis, consist of muscular and aponeurotic fasciculi, which are usually well developed only in the lower part of the thorax. Each arises from the inner surface of one rib near its angle, and is inserted into the inner surface of the second or third rib below. Their fibres run in the same direction as those of the intercostalis interni. The transversus thoracis, triangularis sterni, is a thin plate of muscular and tendinous fibres situated upon the inner surface of the front wall of the chest. It arises on either side from the lower third of the posterior surface of the body of the sternum, from the posterior surface of the xiphoid process, and from the sternal ends of the costal cartilages of the lower 3 or 4 true ribs. Its fibres diverge upward and lateralward, to be inserted by slips into the lower borders and inner surfaces of the costal cartilages of the 2nd, 3rd, 4th, 5th, and 6th ribs. The lowest fibres of this muscle are horizontal in their direction, and are continuous with those of the transversus abdominis. The intermediate fibres are oblique, while the highest are almost vertical. This muscle varies in its attachments, not only in different subjects, but on opposite sides of the same subject. The levatores costarum, 12 in number on either side, are small tendinous and fleshy bundles, which arise from the ends of the transverse processes of the 7th cervical and upper 11 thoracic vertebrae. They pass obliquely downward and lateralward, like the fibres of the intercostalis externi, and each is inserted into the outer surface of the rib immediately below the vertebra from which it takes origin, between the tubercle and the angle, levatores costarum breves. Each of the 4 lower muscles divides into 2 fasciculae, one of which is inserted as above described, the other passes down to the second rib below its origin, levatores costarum longi. The serratus posterior superior, serratus posticus superior, is a thin quadrilateral muscle situated at the upper and back part of the thorax. It arises by a thin and broad aponeurosis from the lower part of the ligamentum nuchae, from the spinous processes of the 7th cervical and upper 2 or 3 thoracic vertebrae, and from the supraspinal ligament. Inclining downward and lateralward it becomes muscular, and is inserted, by 4 fleshy digitations, into the upper borders of the 2nd, 3rd, 4th, and 5th ribs, a little beyond their angles. Variations. Increase or decrease in size and number of slips, or entire absence. The serratus posterior inferior, serratus posticus inferior, is situated at the junction of the thoracic and lumbar regions. It is of an irregularly quadrilateral form, broader than the preceding, and separated from it by a wide interval. It arises by a thin aponeurosis from the spinous processes of the lower 2 thoracic and upper 2 or 3 lumbar vertebrae, and from the supraspinal ligament. Passing obliquely upward and lateralward, it becomes fleshy, and divides into 4 flat digitations, which are inserted into the inferior borders of the lower 4 ribs, a little beyond their angles. The thin aponeurosis of origin is intimately blended with the lumbar-dorsal fascia, and aponeurosis of the latissimus dorsi. Variations. Increase or decrease in size and number of slips, or entire absence. Nerves. The muscles of this group are supplied by the intercostal nerves. The diaphragm is a dome-shaped muscular fibrous septum which separates the thoracic from the abdominal cavity, its convex upper surface forming the floor of the former, and its concave under surface the roof of the latter. Its peripheral part consists of muscular fibres which take origin from the circumference of the thoracic outlet and converge to be inserted into a central tendon. The muscular fibres may be grouped according to their origins into 3 parts: sternal, costal, and lumbar. The sternal part arises by 2 fleshy slips from the back of the xiphoid process, the costal part from the inner surfaces of the cartilages and adjacent portions of the lower 6 ribs on either side, interdigitating with the transversus abdominis, and the lumbar part from the aponeurotic arches, named the lumbocostal arches, and from the lumbar vertebrae by 2 pillars or crura. There are 2 lumbocostal arches, a medial and a lateral on either side. The medial lumbocostal arch, arcus lumbocostalis medialis, Haleri, internal arcuate ligament, is a tendinous arch in the fascia covering the upper part of the psoas major. Medially it is continuous with the lateral tendinous margin of the corresponding crus, and is attached to the side of the body of the 1st or 2nd lumbar vertebra. Laterally it is fixed to the front of the transverse process of the 1st, and sometimes also to that of the 2nd lumbar vertebra. The lateral lumbocostal arch, arcus lumbocostalis lateralis, Haleri, external arcuate ligament, arches across the upper part of the quadratus lumborum, and is attached, medially, to the front of the transverse process of the 1st lumbar vertebra, and, laterally, to the tip and lower margin of the 12th rib. The crura. At their origins the crura are tendinous in structure, and blend with the anterior longitudinal ligament of the vertebral column. The right crus, larger and longer than the left, arises from the anterior surfaces of the bodies and intervertebral fibrocartilages of the upper 3 lumbar vertebrae, while the left crus arises from the corresponding parts of the upper 2 only. The medial tendinous margins of the crura pass forward and medialward, and meet in the middle line to form an arch across the front of the aorta. This arch is often poorly defined. From this series of origins the fibres of the diaphragm converge to be inserted into the central tendon. The fibres arising from the xiphoid process are very short and occasionally aponeurotic. Those from the medial and lateral lumbocostal arches, and more especially those from the ribs and their cartilages, are longer, and describe marked curves as they ascend and converge to their insertion. The fibres of the crura diverge as they ascend, the most lateral being directed upward and lateralward to the central tendon. The medial fibres of the right crus ascend on the left side of the esophageal hiatus, and occasionally a fasciculus of the left crus crosses the aorta and runs obliquely through the fibres of the right crus toward the vena cava foramen. The central tendon. The central tendon of the diaphragm is a thin but strong aponeurosis situated near the centre of the vault formed by the muscle, but somewhat closer to the front than to the back of the thorax, so that the posterior muscular fibres are the longer. It is situated immediately below the pericardium, with which it is partially blended. It is shaped somewhat like a trefoil leaf, consisting of 3 divisions or leaflets separated from one another by slight indentations. The right leaflet is the largest, the middle directed towards the xiphoid process, the next in size, and the left the smallest. In structure the tendon is composed of several planes of fibres, which intersect one another at various angles and unite into straight or curved bundles, an arrangement which gives it additional strength. End of section number 36. Section 37 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2 by Henry Gray. Muscles of the Thorax, Part 2. Openings in the diaphragm. The diaphragm is pierced by a series of apertures to permit of the passage of structures between the thorax and the abdomen. 3 large openings, the aortic, the esophageal, and the vena cava, and a series of smaller ones are described. The aortic hiatus is the lowest and most posterior of the large apertures. It lies at the level of the 12th thoracic vertebra. Strictly speaking, it is not an aperture in the diaphragm, but an osseo-aponeurotic opening between it and the vertebral column, and therefore behind the diaphragm. Occasionally some tendinous fibres, prolonged across the bodies of the vertebrae from the medial part of the lower ends of the crura, pass behind the aorta, and thus convert the hiatus into a fibrous ring. The hiatus is situated slightly to the left of the middle line, and is bounded in front by the crura, and behind by the body of the first lumbar vertebra. Through it pass the aorta, the azygos vein, and the thoracic duct. Occasionally the azygos vein is transmitted through the right crus. The esophageal hiatus is situated in the muscular part of the diaphragm at the level of the 10th thoracic vertebra, and is elliptical in shape. It is placed above, in front, and a little to the left of the aortic hiatus, and transmits the esophagus, the vagus nerves, and some small esophageal arteries. The vena cava foramen is the highest of the 3, and is situated about the level of the fibrocartilage between the 8th and 9th thoracic vertebrae. It is quadrilateral in form, and is placed at the junction of the right and middle leaflets of the central tendon, so that its margins are tendinous. It transmits the inferior vena cava, the wall of which is adherent to the margins of the opening, and some lesser branches of the right phrenic nerve. Of the lesser apertures, 2 in the right crus transmit the greater and lesser right splanchnic nerves. 3 in the left crus give passage to the greater and lesser left splanchnic nerves and the hemiazygos vein. The gangliated trunks of the sympathetic usually enter the abdominal cavity behind the diaphragm, under the medial lumbocostal arches. On either side 2 small intervals exist at which the muscular fibres of the diaphragm are deficient, and are replaced by areolar tissue. One between the sternal and costal parts transmits the superior epigastric branch of the internal mammary artery, and some lymphatics from the abdominal wall and convex surface of the liver. The other, between the fibres springing from the medial and lateral lumbocostal arches, is less constant. When this interval exists, the upper and back part of the kidney is separated from the pleura by areolar tissue only. Variations. The sternal portion of the muscle is sometimes wanting, and more rarely defects occur in the lateral part of the central tendon or adjoining muscle fibres. Nerves. The diaphragm is supplied by the phrenic and lower intercostal nerves. Actions. The diaphragm is the principal muscle of inspiration, and presents the form of a dome concave towards the abdomen. The central part of the dome is tendinous, and the pericardium is attached to its upper surface. The circumference is muscular. During inspiration the lowest ribs are fixed, and from these and the crura the muscular fibres contract and draw downward and forward the central tendon with the attached pericardium. In this movement the curvature of the diaphragm is scarcely altered. the dome moving downward nearly parallel to its original position and pushing before it the abdominal viscera. The descent of the abdominal viscera is permitted by the elasticity of the abdominal wall, but the limit of this is soon reached. The central tendon applied to the abdominal viscera then becomes a fixed point for the action of the diaphragm, the effect of which is to elevate the lower ribs and through them to push forward the body of the sternum and the upper ribs. The right cupola of the diaphragm, lying on the liver, has a greater resistance to overcome than the left, which lies over the stomach, but to compensate for this the right crus and the fibres of the right side generally are stronger than those of the left. In all expulsive acts the diaphragm is called into action to give additional power to each expulsive effort. Thus, before sneezing, coughing, laughing, crying, or vomiting, and previous to the expulsion of urine or feces, or of the fetus from the uterus, a deep inspiration takes place. The height of the diaphragm is constantly varying during respiration. It also varies with the degree of distension of the stomach and intestines and with the size of the liver. After a forced expiration, the right cupola is on a level in front with the fourth costal cartilage, at the side with the fifth, sixth, and seventh ribs, and behind with the eighth rib. The left cupola is a little lower than the right. Hall's-Daly, Journal of Anatomy and Physiology, 1908, volume XL III, states that the absolute range of movement between deep inspiration and deep expiration averages in the male and female 30 mm on the right side and 28 mm on the left. In quiet respiration the average movement is 12.5 mm on the right side and 12 mm on the left. Skiography shows that the height of the diaphragm in the thorax varies considerably with the position of the body. It stands highest when the body is horizontal and the patient on his back, and in this position it performs the largest respiratory excursions with normal breathing. When the body is erect, the dome of the diaphragm falls, and its respiratory movements become smaller. The dome falls still lower when the sitting posture is assumed, and in this position its respiratory excursions are smallest. These facts may, perhaps, explain why it is that patients suffering from severe dyspnea are most comfortable and least short of breath when they sit up. When the body is horizontal and the patient on his side, the two halves of the diaphragm do not behave alike. The uppermost half sinks to a level lower even than when the patient sits, and moves little with respiration. The lower half rises higher in the thorax than it does when the patient is supine, and its respiratory excursions are much increased. In unilateral disease of the pleura or lungs analogous interference with the position or movement of the diaphragm can generally be observed skiographically. It appears that the position of the diaphragm in the thorax depends upon three main factors, viz. 1. The elastic retraction of the lung tissue tending to pull it upward. 2. The pressure exerted on its undersurface by the viscera. This naturally tends to be a negative pressure, or downward suction, when the patient sits or stands, and positive, or an upward pressure, when he lies. 3. The intra-abdominal tension due to the abdominal muscles. These are in a state of contraction in the standing position and not in the sitting, hence the diaphragm, when the patient stands, is pushed up higher than when he sits. The intercostales interni and externi have probably no action in moving the ribs. They contract simultaneously and form strong elastic supports which prevent the intercostal spaces being pushed out or drawn in during respiration. The anterior portions of the intercostales interni probably have an additional function in keeping the sternocostal and intercondral joint surfaces in apposition. The posterior parts of the intercostales externi performing a similar function for the costovertebral articulations. The levatores costarum being inserted near the fulcra of the ribs can have little action on the ribs. They act as rotators and lateral flexors of the vertebral column. The transversus thoracis draws down the costal cartilages, and is therefore a muscle of expiration. The serrati are respiratory muscles. The serratus posterior superior elevates the ribs and is therefore an inspiratory muscle. The serratus posterior inferior draws the lower ribs downward and backward, and thus elongates the thorax. It also fixes the lower ribs, thus assisting the inspiratory action of the diaphragm and resisting the tendency it has to draw the lower ribs upward and forward. It must therefore be regarded as a muscle of inspiration. Mechanism of respiration. The respiratory movements must be examined during a. Quiet respiration and b. Deep respiration. Quiet respiration. The first and second pairs of ribs are fixed by the resistance of the cervical structures, the last pair, and through it the 11th, by the quadratus lumborum. The other ribs are elevated so that the first two intercostal spaces are diminished while the others are increased in width. It has already been shown that elevation of the third, fourth, fifth, and sixth ribs leads to an increase in the antero-posterior and transverse diameters of the thorax. The vertical diameter is increased by the descent of the diaphragmatic dome so that the lungs are expanded in all directions except backward and upward. Elevation of the 8th, 9th, and 10th ribs is accompanied by a lateral and backward movement, leading to an increase in the transverse diameter of the upper part of the abdomen. The elasticity of the anterior abdominal wall allows a slight increase in the antero-posterior diameter of this part, and in this way the decrease in the vertical diameter of the abdomen is compensated and space provided for its displaced viscera. Expiration is effected by the elastic recoil of its walls and by the action of the abdominal muscles, which push back the viscera displaced downward by the diaphragm. Deep respiration. All the movements of quiet respiration are here carried out, but to a greater extent. In deep inspiration the shoulders and the vertebral borders of the scapulae are fixed and the limb muscles, trapezius, serratus anterior, pectoralis, and latissimus dorsi are called into play. The scaleni are in strong action, and the sternocleidomastoideae also assist when the head is fixed by drawing up the sternum and by fixing the clavicles. The first rib is therefore no longer stationary, but, with the sternum, is raised. With it all the other ribs except the last are raised to a higher level. In conjunction with the increased descent of the diaphragm, this provides for a considerable augmentation of all the thoracic diameters. The anterior abdominal muscles come into action so that the umbilicus is drawn upward and backward, but this allows the diaphragm to exert a more powerful influence on the lower ribs. Transverse diameter of the upper part of the abdomen is greatly increased and the subcostal angle opened out. The deeper muscles of the back, e.g. the serrati posteriores superiores and the sacrospinalis and their continuations, are also brought into action. The thoracic curve of the vertebral column is partially straightened, and the whole column, above the lower lumbar vertebrae, drawn backward. This increases the antero-posterior diameters of the thorax and upper part of the abdomen and widens the intercostal spaces. Deep expiration is effected by the recoil of the walls and by the contraction of the anterolateral muscles of the abdominal wall, and the serrati posteriores inferiores and transversus thoracis. Hall's-Daly, ob. Cit., gives the following figures as representing the average changes which occurred during deepest possible respiration. The manubrium sterni moves 30 mm in an upward and 14 mm in a forward direction. The width of the subcostal angle, at a level of 30 mm below the articulation between the body of the sternum and the xiphoid process, is increased by 26 mm. The umbilicus is retracted and drawn upward for a distance of 13 mm. End of section 37.
Section 38 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. To find out more information or to volunteer, please visit LibriVox.org. Recording by Rebecca Case. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles and Fascia of the Abdomen, Part 1. The muscles of the abdomen may be divided into two groups. 1. The anterolateral muscles. 2. The posterior muscles. 1. The anterolateral muscles of the abdomen. The muscles of this group are obliquus externus, obliquus internus, transversus, rectus, pyramidalis. The superficial fascia. The superficial fascia of the abdomen consists, over the greater part of the abdominal wall, of a single layer containing a variable amount of fat, but near the groin it is easily divisible into 2 layers, between which are found the superficial vessels and nerves and the superficial inguinal lymph glands. The superficial layer, fascia of Camper, is thick, areolar in texture, and contains in its meshes a varying quantity of adipose tissue. Below, it passes over the inguinal ligament and is continuous with the superficial fascia of the thigh. In the male, Camper's fascia is continued over the penis and outer surface of the spermatic cord to the scrotum, where it helps to form the dartos. As it passes to the scrotum, it changes its characteristics, becoming thin, destitute of adipose tissue, and of a pale reddish color, and in the scrotum it acquires some involuntary muscular fibers. From the scrotum it may be traced backward into continuity with the superficial fascia of the perineum. In the female, Camper's fascia is continued from the abdomen into the labia majora. The deep layer, fascia of Scarpa, is thinner and more membranous in character than the superficial, and contains a considerable quantity of yellow elastic fibers. It is loosely connected by areolar tissue to the aponeurosis of the obliquus externus abdominis, but in the middle line it is more intimately adherent to the linea alba and to the pubic symphysis, and is prolonged onto the dorsum of the penis, forming the fundiform ligament. Above, it is continuous with the superficial fascia over the rest of the trunk. Below and laterally, it blends with the fascia lata of the thigh a little below the inguinal ligament. Medially and below, it is continued over the penis and spermatic cord to the scrotum, where it helps to form the dartos. From the scrotum, it may be traced backward into continuity with the deep layer of the superficial fascia of the perineum, fascia of Colles. In the female, it is continued into the labia majora and thence to the fascia of Colles. The obliquus externus abdominis, external or descending oblique muscle, situated on the lateral and anterior parts of the abdomen, is the largest and the most superficial of the 3 flat muscles in this region. It is broad, thin, and irregularly quadrilateral, its muscular portion occupying the side, its aponeurosis the anterior wall of the abdomen. It arises by 8 fleshy digitations from the external surfaces and inferior borders of the lower 8 ribs. These digitations are arranged in an oblique line which run downward and backward, the upper ones being attached close to the cartilages of the corresponding ribs, the lowest to the apex of the cartilage of the last rib, the intermediate ones to the ribs at some distance from their cartilages. The 5 superior serrations increase in size from above downward and are received between corresponding processes of the serratus anterior. The 3 lower ones diminish in size from above downward and receive between them corresponding processes from the latissimus dorsi. From these attachments, the fleshy fibers proceed in various directions. Those from the lowest ribs pass nearly vertically downward and are inserted into the anterior half of the outer lip of the iliac crest. The middle and upper fibers, directed downward and forward, end in an aponeurosis, opposite a line drawn from the prominence of the 9th costal cartilage to the anterior superior iliac spine. The aponeurosis of the obliquus externus abdominis is a thin but strong membranous structure, the fibers of which are directed downward and medialward. It is joined with that of the opposite muscle along the middle line and covers the whole of the front of the abdomen. Above, it is covered by and gives origin to the lower fibers of the pectoralis major. Below, its fibers are closely aggregated together and extend obliquely across from the anterior superior iliac spine to the pubic tubercle and the pectineal line. In the middle line, it interlaces with the aponeurosis of the opposite muscle, forming the linea alba, which extends from the xiphoid process to the symphysis pubis. That portion of the aponeurosis which extends between the anterior superior iliac spine and the pubic tubercle is a thick band, folded inward and continuous below with the fascia lata. It is called the inguinal ligament. The portion which is reflected from the inguinal ligament at the pubic tubercle is attached to the pectineal line and is called the lacunar ligament. From the point of attachment of the latter to the pectineal line, a few fibers pass upward and medialward behind the medial crus of the subcutaneous inguinal ring to the linea alba. They diverge as they ascend and form a thin triangular fibrous band which is called the reflected inguinal ligament. In the aponeurosis of the obliquus externus, immediately above the crest of the pubis, is a triangular opening, the cutaneous inguinal ring, formed by a separation of the fibers of the aponeurosis in this situation. The following structures require further description, viz., the subcutaneous inguinal ring, the intracrural fibers and fascia, and the inguinal, lacunar, and reflected inguinal ligaments. The subcutaneous inguinal ring, annulus inguinus subcutaneous, external abdominal ring. The subcutaneous inguinal ring is an interval in the aponeurosis of the obliquus externus, just above and lateral to the crest of the pubis. The aperture is oblique in direction, somewhat triangular in form, and corresponds with the course of the fibers of the aponeurosis. It usually measures from base to apex about 2.5 centimeters and transversely about 1.25 centimeters. It is bounded below by the crest of the pubis, on either side by the margins of the opening in the aponeurosis, which are called the crura of the ring, and above by a series of curved intracrural fibers. The inferior crus, external pillar, is the stronger and is formed by that portion of the inguinal ligament which is inserted into the pubic tubercle. It is curved so as to form a kind of groove, upon which, in the male, the spermatic cord rests. The superior crus, or internal pillar, is a broad, thin, flat band attached to the front of the symphysis pubis and interlacing with its fellow on the opposite side. The subcutaneous inguinal ring gives passage to the spermatic cord and ilioinguinal nerve in the male, and to the round ligament of the uterus and the ilioinguinal nerve in the female. It is much larger in men than in women on account of the large size of the spermatic cord. The intracrural fibers, fibrae intracruralis, intercolumnar fibers. The intracrural fibers are a series of curved tendinous fibers which arch across the lower part of the aponeurosis of the obliquus externus, describing curves with the convexities downward. They have received their name from stretching across between the two crura of the subcutaneous inguinal ring, and they are much thicker and stronger at the inferior crus, where they are connected to the inguinal ligament, than superiorly, where they are inserted into the linea alba. The intracrural fibers increase the strength of the lower part of the aponeurosis and prevent the divergence of the crura from one another. They are more strongly developed in the male than in the female. As they pass across the subcutaneous inguinal ring, they are connected together by delicate fibrous tissue, forming a fascia, called the intracrural fascia. This intracrural fascia is continued down as a tubular prolongation around the spermatic cord and testes, and encloses them in a sheath. Hence it is also called the external spermatic fascia. The subcutaneous inguinal ring is seen as a distinct aperture only after the intracrural fascia has been removed. The inguinal ligament, ligamentum inguinale, Poparte, or Popart's ligament. The inguinal ligament is the lower border of the aponeurosis of the obliquus externus, and extends from the anterior superior iliac spine to the pubic tubercle. From this latter point it is reflected backward and lateralward to be attached to the pectineal line for about 1.25 centimeters, forming the lacunar ligament. Its general direction is convex downward toward the thigh, where it is continuous with the fascia lata. Its lateral half is rounded and oblique in direction. Its medial half gradually widens at its attachment to the pubis, and is more horizontal in direction, and lies beneath the spermatic cord. The lacunar ligament, ligamentum lacunar Gimbernati, Gimbernaut's ligament. The lacunar ligament is that part of the aponeurosis of the obliquus externus which is reflected backward and lateralward and is attached to the pectineal line. It is about 1.25 centimeters long, larger in the male than in the female, almost horizontal in direction in the erect posture, and of a triangular form with the base directed lateralward. Its base is concave, thin, and sharp, and forms the medial boundary of the femoral ring. Its apex corresponds to the pubic tubercle. Its posterior margin is attached to the pectineal line and is continuous with the pectineal fascia. Its anterior margin is attached to the inguinal ligament. Its surfaces are directed upward and downward. The reflected inguinal ligament, ligamentum inguinale reflexum, colesi, triangular fascia. The reflected inguinal ligament is a layer of tendinous fibers of a triangular shape, formed by an expansion from the lacunar ligament and the inferior crus of the subcutaneous inguinal ring. It passes medialward behind the spermatic cord and expands into a somewhat fan-shaped band lying behind the superior crus of the subcutaneous inguinal ring and in front of the inguinal aponeurotic falx, and interlaces with the ligament on the other side of the linea alba. Ligament of Cooper. This is a strong fibrous band which was first described by Sir Astley Cooper. It extends lateralward from the base of the lacunar ligament along the pectineal line to which it is attached. It is strengthened by the pectineal fascia and by a lateral expansion from the lower attachment of the linea alba. Ad maniculum lineae albae. Variations. The obliquus externus may show decrease or doubling of its attachments to the ribs. Addition slips from lumbar aponeurosis. Doubling between lower ribs and ilium or inguinal ligament. Rarely tendinous inscriptions occur. The obliquus internus abdominis, internal or ascending oblique muscle, thinner and smaller than the obliquus externus, beneath which it lies, is of an irregularly quadrilateral form and situated at the lateral and anterior parts of the abdomen. It arises, by fleshy fibers, from the lateral half of the grooved upper surface of the inguinal ligament, from the anterior 2/3 of the middle lip of the iliac crest, and from the posterior lamina of the lumbodorsal fascia. From this origin the fibers diverge. Those from the inguinal ligament, few in number and paler in color than the rest, arch downward and medialward across the spermatic cord in the male and the round ligament of the uterus in the female, and, becoming tendinous, are inserted, conjointly with those of the transversus, into the crest of the pubis and medial part of the pectineal line behind the lacunar ligament, forming what is known as the inguinal aponeurotic falx. Those from the anterior third of the iliac origin are horizontal in their direction and, becoming tendinous along the lower fourth of the linea semilunaris, pass in front of the rectus abdominis to be inserted into the linea alba. Those arising from the middle third of the iliac origin run obliquely upward and medialward and end in an aponeurosis. This divides at the lateral border of the rectus into two laminae, which are continued forward, one in front of and the other behind this muscle, to the linea alba. The posterior lamina has an attachment to the cartilages of the 7th, 8th, and 9th ribs. The most posterior fibers pass almost vertically upward, to be inserted into the inferior borders of the cartilages of the lower 3 ribs, being continuous with the intercostalis interni. Variations. Occasionally, tendinous inscriptions occur from the tips of the 10th or 11th cartilages, or even from the 9th. An additional slip to the 9th cartilage is sometimes found. Separation between iliac and inguinal parts may occur. End of section 38. Section 39 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. To find out more information or to volunteer, please visit LibriVox.org. Recording by Rebecca Case. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles and Fascia of the Abdomen, Part 2. The cremaster is a thin muscular layer composed of a number of fasciculi which arise from the middle of the inguinal ligament, where its fibers are continuous with those of the obliquus internus, and also occasionally with the transversus. It passes along the lateral side of the spermatic cord, descends with it through the subcutaneous inguinal ring upon the front and sides of the cord, and forms a series of loops which differ in thickness and length in different subjects. At the upper part of the cord the loops are short, but they become in succession longer and longer, the longest reaching down as low as the testis, where a few are inserted into the tunica vaginalis. These loops are united together by areolar tissue and form a thin covering over the cord and testis, the cremasteric fascia. The fibers ascend along the medial side of the cord and are inserted by a small pointed tendon into the tubercle and crest of the pubis, and into the front of the sheath of the rectus abdominis. The transversus abdominis, transversalis muscle, so called from the direction of its fibers, is the most internal of the flat muscles of the abdomen, being placed immediately beneath the obliquus internus. It arises, by fleshy fibers, from the lateral third of the inguinal ligament, from the anterior 3/4 of the inner lip of the iliac crest, from the inner surfaces of the cartilages of the lower 6 ribs, interdigitating with the diaphragm, and from the lumbo-dorsal fascia. The muscle ends in front in a broad aponeurosis, the lower fibers of which curve downward and medialward, and are inserted, together with those of the obliquus internus, into the crest of the pubis and pectineal line, forming the inguinal aponeurotic falx. Throughout the rest of its extent, the aponeurosis passes horizontally to the middle line, as inserted into the linea alba. Its upper 3/4 lie behind the rectus and blend with the posterior lamina of the aponeurosis of the obliquus internus. Its lower 4th is in front of the rectus. Variations. It may be more or less fused with the obliquus internus or absent. The spermatic cord may pierce its lower border. Slender muscle slips from the iliopectineal line to transversalis fascia, the aponeurosis of the transversus abdominis, or the outer end of the linea semicircularis, and other slender slips are occasionally found. The inguinal aponeurotic falx, falx aponeurotica inguinalis, conjoined tendon of internal oblique and transversalis muscle, of the obliquus internus and transversus, is mainly formed by the lower part of the tendon of the transversus, and is inserted into the crest of the pubis and pectineal line immediately behind the subcutaneous inguinal ring, serving to protect what would otherwise be a weak point in the abdominal wall. Lateral to the falx is a ligamentous band connected with the lower margin of the transversus and extending down in front of the inferior epigastric artery to the superior ramus of the pubis. It is termed the interfoveolar ligament of Hasselbeck and sometimes contains a few muscular fibers. The rectus abdominis is a long, flat muscle which extends along the whole length of the front of the abdomen and is separated from its fellow on the opposite side by the linea alba. It is much broader, but thinner, above than below, and arises by 2 tendons. The lateral, or larger, is attached to the crest of the pubis, the medial interlaces with its fellow of the opposite side, and is connected with the ligaments covering the front of the symphysis pubis. The muscle is inserted by 3 portions of unequal size into the cartilages of the 5th, 6th, and 7th ribs. The upper portion, attached principally to the cartilage of the 5th rib, usually has some fibers of insertion into the anterior extremity of the rib itself. Some fibers are occasionally connected with the costoxiphoid ligaments and the side of the xiphoid process. The rectus is crossed by fibrous bands, 3 in number, which are named the tendinous inscriptions. One is usually situated opposite the umbilicus, one at the extremity of the xiphoid process, and the third about midway between the xiphoid process and the umbilicus. These inscriptions pass transversely or obliquely across the muscle in a zigzag course. They rarely extend completely through its substance and may pass only halfway across it. They are intimately adherent in front to the sheath of the muscle. Sometimes one or two additional inscriptions, generally incomplete, are present below the umbilicus. The rectus is enclosed in a sheath formed by the aponeurosis of the obliqui and transversus, which are arranged in the following manner. At the lateral margin of the rectus, the aponeurosis of the obliquus internus divides into two laminae, one of which passes in front of the rectus, blending with the aponeurosis of the obliquus externus, the other behind it, blending with the aponeurosis of the transversus, and these, joining again at the medial border of the rectus, are inserted into the linea alba. This arrangement of the aponeurosis exists from the costal margin to midway between the umbilicus and the symphysis pubis, where the posterior wall of the sheath ends in a thin curved margin, the linea semicircularis, the concavity of which is directed downward. Below this level the aponeurosis of all three muscles passes in front of the rectus. The rectus, in the situation where its sheath is deficient below, is separated from the peritoneum by the transversalis fascia. Since the tendons of the obliquus internus and transversus only reach as high as the costal margin, it follows that above this level the sheath of the rectus is deficient behind, the muscle resting directly on the cartilages of the ribs, and being covered merely by the tendon of the obliquus externus. The pyramidalis is a small triangular muscle placed at the lower part of the abdomen in front of the rectus and contained in the sheath of that muscle. It arises by tendinous fibers from the front of the pubis and the anterior pubic ligament. The fleshy portion of the muscle passes upward, diminishing in size as it ascends, and ends by a pointed extremity which is inserted into the linea alba, midway between the umbilicus and pubis. This muscle may be wanting on one or both sides. The lower end of the rectus then becomes proportionately increased in size. Occasionally it is double on one side, and the muscles of the two sides are sometimes of unequal size. It may extend higher than the level stated. Beside the rectus and pyramidalis, the sheath of the rectus contains the superior and inferior epigastric arteries and the lower intercostal nerves. Variations. The rectus may insert as high as the fourth or third rib, or may fail to reach the fifth. Fibers may spring from the lower part of the linea alba. Nerves. The abdominal muscles are supplied by the lower intercostal nerves. The obliquus internus and transversus also receive filaments from the anterior branch of the iliohypogastric and sometimes from the ilioinguinal. The cremaster is supplied by the external spermatic branch of the genitofemoral and the pyramidalis usually by the 12th thoracic. The linea alba. The linea alba is a tendinous raphe in the middle line of the abdomen, stretching between the xiphoid process and the symphysis pubis. It is placed between the medial borders of the recti and is formed by the blending of the aponeurosis of the obliqui and transversi. It is narrow below, corresponding to the linear interval existing between the recti, but broader above, where these muscles diverge from one another. At its lower end the linea alba has a double attachment, its superficial fibers passing in front of the medial heads of the recti to the symphysis pubis, while its deeper fibers form a triangular lamina, attached behind the recti to the posterior lip of the crest of the pubis, and named the admeniculum lineae albae. It presents apertures for the passage of vessels and nerves. The umbilicus, which in the fetus exists as an aperture and transmits the umbilical vessels, is closed in the adult. The lineae semilunaris. The lineae seminularis are two curved tendinous lines placed one on either side of the linea alba. Each corresponds with the lateral border of the rectus, extends from the cartilage of the ninth rib to the pubic tubercle, and is formed by the aponeurosis of the obliquus internus at its line of division to enclose the rectus, reinforced in front by that of the obliquus externus and behind by that of the transversus. Actions. When the pelvis and thorax are fixed, the abdominal muscles compress the abdominal viscera by constricting the cavity of the abdomen, in which action they are materially assisted by the descent of the diaphragm. By these means assistance is given in expelling the feces from the rectum, the urine from the bladder, the fetus from the uterus, and the contents of the stomach in vomiting. If the pelvis and the vertebral column be fixed, these muscles compress the lower part of the thorax, materially assisting expiration. If the pelvis alone be fixed, the thorax is bent directly forward when the muscles of both sides act. When the muscles of only one side contract, the trunk is bent toward that side and rotated toward the opposite side. If the thorax be fixed, the muscles, acting together, draw the pelvis upward, as in climbing, or, acting singly, they draw the pelvis upward and bend the vertebral column to one side or the other. The recti, acting from below, depress the thorax and consequently flex the vertebral column. When acting from above, they flex the pelvis upon the vertebral column. The pyramidalis are tensors of the linea alba. The transversalis fascia. The transversalis fascia is a thin aponeurotic membrane which lies between the inner surface of the transversus and the extraperitoneal fat. It forms part of the general layer of fascia lining the abdominal parodes and is directly continuous with the iliac and pelvic fasciae. In the inguinal region, the transversalis fascia is thick and dense in structure and is joined by fibers from the aponeurosis of the transversus, but it becomes thin as it ascends to the diaphragm and blends with the fascia covering the undersurface of this muscle. Behind, it is lost in the fat which covers the posterior surfaces of the kidney. Below, it has the following attachments. Posteriorly, to the whole length of the iliac crest, between the attachments of the transversus and iliacus. Between the anterior superior iliac spine and the femoral vessels, it is connected to the posterior margin of the inguinal ligament, and is there continuous with the iliac fascia. Medial to the femoral vessels, it is thin and attached to the pubis and pectineal line, behind the inguinal aponeurotic falx, with which it is united. It descends in front of the femoral vessels to form the anterior wall of the femoral sheath. Beneath the inguinal ligament it is strengthened by a band of fibrous tissue, which is only loosely connected to the ligament, and is specialized as a deep crural arch. The spermatic cord in the male and the round ligament of the uterus in the female pass through the transversalis fascia at a spot called the abdominal inguinal ring. This opening is not visible externally, since the transversalis fascia is prolonged on these structures as the infundibuliform fascia. The abdominal inguinal ring. Annulus inguinalis abdominis, internal or deep abdominal ring. The abdominal inguinal ring is situated in the transversalis fascia, midway between the anterior superior iliac spine and the symphysis pubis, and about 1.25 centimeters above the inguinal ligament. It is of an oval form, the long axis of the oval being vertical. It varies in size in different subjects, and is much larger in the male than in the female. It is bounded, above and laterally, by the arched lower margins of the transversus, below and medially by the inferior epigastric vessels. It transmits the spermatic cord in the male and the round ligament of the uterus in the female. From its circumference, a thin funnel-shaped membrane, the infundibuliform fascia, is continued around the cord and the testis, enclosing them in a distinct covering. The inguinal canal. Canalis inguinalis, spermatic canal. The inguinal canal contains the spermatic cord and the ilioinguinal nerve in the male, and the round ligament of the uterus and the ilioinguinal nerve in the female. It is an oblique canal about 4 centimeters long, slanting downward and medialward, and placed parallel with and a little above the inguinal ligament. It extends from the abdominal inguinal ring to the subcutaneous inguinal ring. It is bounded in front by the integument and superficial fascia, by the aponeurosis of the obliquus externus throughout its whole length, and by the obliquus internus in its lateral third. Behind, by the reflected inguinal ligament, the inguinal aponeurotic falx, the transversalis fascia, the extraperitoneal connective tissue, and the peritoneum. Above, by the arched fibers of the obliquus internus and the transversus abdominis. Below, by the union of the transversalis fascia with the inguinal ligament, and at its medial end by the lacunar ligament. Extraperitoneal connective tissue. Between the inner surface of the general layer of the fascia, which lines the interior of the abdominal and pelvic cavities, and the peritoneum, there is a considerable amount of connective tissue termed the extraperitoneal or subperitoneal connective tissue. The parietal portion lines the cavity in varying quantities in different situations. It is especially abundant on the posterior wall of the abdomen, and particularly around the kidneys, where it contains much fat. On the anterior wall of the abdomen, except in the pubic region, and on the lateral wall above the iliac crest, it is scanty, and here the transversalis fascia is more closely connected with the peritoneum. There is a considerable amount of extraperitoneal connective tissue in the pelvis. The visceral portion follows the course of the branches of the abdominal aorta between the layers of the mesenterics and other folds of the peritoneum which connect the various viscera to the abdominal wall. The two portions are directly continuous with each other. The deep crural arch. Curving over the external iliac vessels, at the spot where they become femoral, on the abdominal side of the inguinal ligaments and loosely connected with it, is a thickened band of fibers called the deep crural arch. It is apparently a thickening of the transversalis fascia joined laterally to the center of the lower margin of the inguinal ligament, and arching across the front of the femoral sheath to be inserted by a broad attachment into the pubic tubercle and pectineal line, behind the inguinal aponeurotic falx. In some subjects this structure is not very prominently marked, and not infrequently it is altogether wanting. 2. The posterior muscles of the abdomen. Psoas major, psoas minor, iliacus, quadratus lumborum. The psoas major, the psoas minor, and the iliacus, with the fasciae covering them, will be described with the muscles of the lower extremity. See page 466. The fasciae covering the quadratus lumborum. This is a thin layer attached medially to the bases of the transverse processes of the lumbar vertebrae, below to the iliolumbar ligament, above to the apex and lower border of the last rib. The upper margin of this fascia, which extends from the transverse process of the first lumbar vertebra to the apex and lower border of the last rib, constitutes the lateral lumbocostal arch, page 405. Laterally, it blends with the lumbodorsal fascia, the anterior layer of which intervenes between the quadratus lumborum and the sacrospinalis. The quadratus lumborum, page 398, is irregularly quadrilateral in shape and broader above than below. It arises by aponeurotic fibers from the iliolumbar ligament and the adjacent portion of the iliac crest for about 5 centimeters, and is inserted into the lower border of the last rib for about half its length, and by 4 small tendons into the apices of the transverse processes of the upper 4 lumbar vertebrae. Occasionally, a second portion of this muscle is found in front of the preceding. It arises from the upper borders of the transverse processes of the lower 3 or 4 lumbar vertebrae, and is inserted into the lower margin of the last rib. In front of the quadratus lumborum are the colon, the kidney, the psoas major and minor, and the diaphragm. Between the fascia and the muscle are the 12th thoracic, iliolinguinal, and iliohypogastric nerves. Variations. The number of attachments to the vertebrae and the extent of its attachment to the last rib vary. Nerve supply. The 12th thoracic and 1st and 2nd lumbar nerves supply this muscle. Actions. The quadratus lumborum draws down the last rib, and acts as a muscle of inspiration by helping to fix the origin of the diaphragm. If the thorax and vertebral column are fixed, it may act upon the pelvis, raising it toward its own side when only one muscle is put in action, and when both muscles act together, either from below or above, they flex the trunk. End of section 39.
Of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles and fascia of the pelvis. Obturator internus, piriformis, levator ani, coccygeus. The muscles within the pelvis may be divided into two groups. 1. The obturator internus and the piriformis, which are muscles of the lower extremity, and will be described with these. 2. The levator ani and the coccygeus, which together form the pelvic diaphragm, and are associated with the pelvic viscera. The classification of the two groups under a common heading is convenient in connection with the fascia investing the muscles. These fascia are closely related to one another and to the deep fascia of the perineum, and in addition have special connections with the fibrous coverings of the pelvic viscera. It is customary, therefore, to describe them together under the term pelvic fascia. Pelvic fascia. The fascia of the pelvis may be resolved into a. The fascial sheaths of the obturator internus, piriformis, and pelvic diaphragm. b. The fascia associated with the pelvic viscera. The fascia of the obturator internus covers the pelvic surface of, and is attached around, the margin of the origin of, the muscle. Above, it is loosely connected to the back part of the arcuate line, and here it is continuous with the iliac fascia. In front of this, as it follows the line of origin of the obturator internus, it gradually separates from the iliac fascia, and the continuity between the two is retained only through the periosteum. It arches beneath the obturator vessels and nerve, completing the obturator canal, and at the front of the pelvis is attached to the back of the superior ramus of the pubis. Below, the obturator fascia is attached to the falciform process of the sacrotuberous ligament, and to the pubic arch, where it becomes continuous with the superior fascia of the urogenital diaphragm. Behind, it is prolonged into the gluteal region. The internal pudendal vessels and pudendal nerve cross the pelvic surface of the obturator internus, and are enclosed in a special canal, Alcock's canal, formed by the obturator fascia. The fascia of the piriformis is very thin, and is attached to the front of the sacrum and the sides of the greater sciatic foramen. It is prolonged on the muscle into the gluteal region. At its sacral attachment around the margins of the anterior sacral foramina, it comes into intimate association with, and ensheathes, the nerves emerging from these foramina. Hence, the sacral nerves are frequently described as lying behind the fascia. The internal iliac vessels and their branches, on the other hand, lie in the subperitoneal tissue in front of the fascia, and the branches to the gluteal region emerge in special sheaths of this tissue, above and below the piriformis muscle. The diaphragmatic part of the pelvic fascia covers both surfaces of the levatores ani. The inferior layer is known as the anal fascia. It is attached above to the obturator fascia along the line of origin of the levator ani, while below it is continuous with the superior fascia of the urogenital diaphragm, and with the fascia on the sphincter ani internus. The layer covering the upper surface of the pelvic diaphragm follows, above, the line of origin of the levator ani, and is therefore somewhat variable. In front, it is attached to the back of the symphysis pubis, about 2 centimeters above its lower border. It can then be traced laterally across the back of the superior ramus of the pubis for a distance of about 1.25 centimeters, when it reaches the obturator fascia. It is attached to this fascia along a line which pursues a somewhat irregular course to the spine of the ischium. The irregularity of this line is due to the fact that the origin of the levator ani, which in lower forms is from the pelvic brim, is in man lower down, on the obturator fascia. Tendinous fibers of origin of the muscle are therefore often found extending up toward, and in some cases reaching, the pelvic brim, and on these the fascia is carried. It will be evident that the fascia covering that part of the obturator internus which lies above the origin of the levator ani is a composite fascia, and includes the following: a. The obturator fascia. b. The fascia of the levator ani. c. Degenerated fibers of origin of the levator ani. The lower margin of the fascia covering the upper surface of the pelvic diaphragm is attached along the line of insertion of the levator ani. At the level of a line extending from the lower part of the symphysis pubis to the spine of the ischium is a thickened whitish band in this upper layer of the diaphragmatic part of the pelvic fascia. It is termed the tendinous arch, or white line of the pelvic fascia, and marks the line of attachment of the special fascia, pars endopelvina fascia pelvis, which is associated with the pelvic viscera. The endopelvic part of the pelvic fascia is continued over the various pelvic viscera to form for them fibrous coverings which will be described later. See section on splanknology. It is attached to the diaphragmatic part of the pelvic fascia along the tendinous arch, and has been subdivided in accordance with the viscera to which it is related. Thus its anterior part, known as the vesical layer, forms the anterior and lateral ligaments of the bladder. Its middle part crosses the floor of the pelvis between the rectum and vesiculae seminales as the recto-vesical layer. In the female this is perforated by the vagina. Its posterior portion passes to the side of the rectum. It forms a loose sheath for the rectum, but is firmly attached around the anal canal. This portion is known as the rectal layer. The levator ani is a broad, thin muscle situated on the side of the pelvis. It is attached to the inner surface of the side of the lesser pelvis, and unites with its fellow of the opposite side to form the greater part of the floor of the pelvic cavity. It supports the viscera in this cavity, and surrounds the various structures which pass through it. It arises, in front, from the posterior surface of the superior ramus of the pubis lateral to the symphysis, behind, from the inner surface of the spine of the ischium, and between these two points, from the obturator fascia. Posteriorly, this fascial origin corresponds, more or less closely, with the tendinous arch of the pelvic fascia, but in front the muscle arises from the fascia at a varying distance above the arch, in some cases reaching nearly as high as the canal for the obturator vessels and nerve. The fibers pass downward and backward to the middle line of the floor of the pelvis. The most posterior are inserted into the side of the last two segments of the coccyx. Those placed more anteriorly unite with the muscle of the opposite side, in a median fibrous raphe, anococcygeal raphe, which extends between the coccyx and the margin of the anus. The middle fibers are inserted into the side of the rectum, blending with the fibers of the sphincter muscles. Lastly, the anterior fibers descend upon the side of the prostate, to unite beneath it with the muscle of the opposite side, joining with the fibers of the sphincter ani externus and transversus perineae, at the central tendinous point of the perineum. The anterior portion is occasionally separated from the rest of the muscle by connective tissue. From this circumstance, as well as from its peculiar relation with the prostate, which it supports as in a sling, it has been described as a distinct muscle under the name of levator prostatae. In the female, the anterior fibers of the levator ani descend upon the side of the vagina. The levator ani may be divided into iliococcygeal and pubococcygeal parts. The iliococcygeus arises from the ischial spine and from the posterior part of the tendinous arch of the pelvic fascia, and is attached to the coccyx and anococcygeal raphe. It is usually thin, and may fail entirely, or be largely replaced by fibrous tissue. An accessory slip at its posterior part is sometimes named the iliosacralis. The pubococcygeus arises from the back of the pubis and from the anterior part of the obturator fascia, and is directed backward almost horizontally along the side of the anal canal toward the coccyx and sacrum, to which it finds attachment. Between the termination of the vertebral column and the anus, the two pubococcygeal muscles come together and form a thick fibromuscular layer lying on the raphe formed by the iliococcygeae. Peter Thompson. The greater part of this muscle is inserted into the coccyx and into the last one or two pieces of the sacrum. This insertion into the vertebral column is, however, not admitted by all observers. The fibers which form a sling for the rectum are named the puborectalis, or sphincter recti. They arise from the lower part of the symphysis pubis, and from the superior fascia of the urogenital diaphragm. They meet with the corresponding fibers of the opposite side around the lower part of the rectum, and form for it a strong sling. Nerve supply. The levator ani is supplied by a branch from the fourth sacral nerve, and by a branch which is sometimes derived from the perineal, sometimes from the inferior hemorrhoidal division of the pudendal nerve. The coccygus is situated behind the preceding. It is a triangular plane of muscular and tendinous fibers, arising, by its apex, from the spine of the ischium and sacrospinous ligament, and inserted, by its base, into the margin of the coccyx, and into the side of the lowest piece of the sacrum. It assists the levator ani and piriformis in closing in the back part of the outlet of the pelvis. Nerve supply. The coccygus is supplied by a branch from the fourth and fifth sacral nerves. Actions. The levatores ani constrict the lower end of the rectum and vagina. They elevate and invert the lower end of the rectum after it has been protruded and everted during the expulsion of the feces. They are also muscles of forced expiration. The coccygeae pull forward and support the coccyx after it has been pressed backward during defecation or parturition. The levatores ani and coccygeae together form a muscular diaphragm which supports the pelvic viscera. End of section 40.